Good morning, everyone. Thank you very much, Mr. Chairman and ESD Organizing Committee, everyone, to invite us to this prestigious discussion. And as you've said, that this the our floor is very active, and we are seeing that. So thank God there is no hematologist here because I can say whatever I want. But I'm sure you will catch me on something because this topic is very important, and it took me a while to understand, even after practicing, that you know um, about the balancing the bleeding situation. And my main aim today is to review the key anticoagulants and the antiplatelets. And before we go there, including me, we will understand together the main difference and try to memorize it because we are surgeons and we are physicians too. But we need to understand this in a different aspect as well because we don't practice that every day. So we encounter to understand how really this bleeding and thrombotic risks vary across the stone procedures, and to look at the evidence and the guidelines, and on the perioperative management. And I'll finish my practical algorithms and the case discussions then. So we have all encountered this challenging clinical scenarios: a patient presenting with a significant stone burden, but also carries substantial cardiovascular risk and is currently on anticoagulation therapy. The key clinical question which we encounter every day when we are looking at those patients, and more people are elderly now because the healthcare is getting better. There are more elderly people, and more people now are aging, and then obviously when they age, they have cardiovascular issues, and they are put on now very readily available. Before it was warfarin, now there are direct oral anticoagulants. So it's very easy for them to be put on that. So should we delay the surgical intervention? And if so, for how long? Is it necessary to discontinue anticoagulants? And what are the potential risks associated with doing so? Do we have any kind of a measurement to do that, the risks assessment of them? Is bridging anticoagulation required? And if so, what are the protocols should we follow? Managing the situation requires a careful balance. An error in judgment could result in the severe bleeding, obviously, not for me, but for the people who does PCNL, and complications, conversely, leading to thrombotic events such as stroke or embolism during or after the surgery. So event that undeniably can be fatal by just dealing with the stones. Um, some of my colleagues, sometimes ask that, the stone management and cancer management, there's a big difference. The stone management is stone management and functional urology, and the stone management is more dangerous because the patients come in walking in, or sometimes an emergency. Cancer patients, when they come in, they have a cancer and complication happens. It's not a huge big deal, but for a functional urology people and the stone management people, it's a big deal because they walked in and then suddenly if complication happens. So for us, it's a big deal. So this is a very important slide. All of you, I want you to look at very carefully, and I look at it carefully as well. So the main difference between the antiplatelets and anticoagulants. First of all, I think you have to understand these two major difference. And because I've seen people being on anticoagulants, for example, low molecular weight heparin prophylaxis, and somebody sending them home on aspirin. Doesn't make sense. It's nothing to do with that. There are two different things. There are two different mechanisms. There are two different ways of dealing with that. So anticoagulation is different from antiplatelets. Most of you may understand that, but a lot of people don't. So that's why I just thought I'll just bring this topic as well. So the main difference on the pathophysiological level, the difference between the antiplatelets and anticoagulants are both used to prevent the clots, but there is difference in the mechanism and clinical application. Antiplatelets such as aspirin and Plavix, clopidogrel, and inhibits platelet aggregation and are primarily used to prevent arterial thrombus. Think arterial thrombus as the coronary artery, and I sometimes just for an analogy point of view think about as a stricture. In the ureteric stricture, it is just a formation of stricture getting bigger and bigger and bigger, and to prevent that, so you have to make the platelets not sticking to that place. So coronary artery is the main key if you think about it. And then, primarily used to prevent the arterial thrombus, such as, causing the heart attacks and strokes, the carotids as well. You have to think about, and also, and once the drug-eluting stents are put in, the cardiologists usually leave those for about at least a year of antiplatelets, sometimes dual antiplatelet therapy. In contrast, anticoagulants like warfarin, heparin. Warfarin is used less and less now, but sometimes in the mechanical valves they still use it. And direct oral anticoagulants, which are now available, which are apixaban and digabatran, they interfere with the coagulation cascade to prevent the fibrin clot formation, making them more effective for venous thromboembolism. This is also to understand that. And once we understand that, I think it's easy for us to know exactly what we need to do, and obviously the reversal therapies which are available for them. So let's briefly skim through all of that as well. Their antiplatelets, aspirin, the lasting effect of them is about 10 days. The Plavix and Tegretol, both receptors, I think, but they are a bit longer acting, so they need to be stopped at least a week to 10 days before surgery. And the anticoagulants, warfarin remains the common one, but particularly with the mechanical valves, and direct oral anticoagulants are now widely used, like apixaban and rivaroxaban. And low molecular weight heparin, such as enoxaparin, is often used perioperatively for the bridging. So the main indications we encounter are atrial fibrillation, and where we use the CHAD-DS VAS score, and we'll go through that, and I'll make it simple from the urology point of view so that both of us can understand that. And basically the CHAD score, basically to assess the thrombotic risk events and the venous thromboembolic episodes and mechanical valves and recent coronary stenting, and especially if they are still on the dual antiplatelet therapy. So we're going to assess that in a second. Before, we would just categorize the different types of procedures into the low risk, moderate risk, and high risk. And in the high risk procedures, sometimes in high risk CHAD scores, we need to bridge them. But we'll talk about the bridging as well in a second. So this is the CHAD score. This is very important. And if you try to go through that, you can see that CHAD score means CHADVAS, CHAD VAS score. This gives a numbering of this is basically a tool, clinical tool to estimate the risk of the stroke in a patient with atrial fibrillation. And it's very simple. You can do that yourself. In common heart arrhythmias, and help also to guide the treatment decisions, particularly regarding the anticoagulation, whether we need to bridge this or not. And again, I'm stressing that we come to the bridging issue as well in a minute. So there is a number for each. So for example, if somebody has got a congestive cardiac failure, which means that the ejection fraction is less than 40, then we give him 1 score. Somebody who has hypertension, the age is 75, it means 2. If it is less than 65, it is 1, and then so on and so forth, the scoring system. And I think the marking is 5. Anything above 5 is a problem. That is a high risk patient, and then we may have to think about, if the CHAD score is above 5, we have to think about bridging them. Otherwise, bridging is not necessary, and I'll talk to you in a second about that. So on the other hand, we have thrombotic risk based on the indication and history. High risk, like the recent venous thromboembolism, mechanical mitral valve, or CHAD score of 5 and above. And moderate risks are CHAD score is less than 3, between 3 and 4, and the low risk people are who have a long resolved VT, and the pulmonary embolism was 6 months ago. So I put a question to you first. Before we go into this move, do you ask your patient to stop the anticoagulants, or do you bridge them? What timings do you use, both pre and post-op, and is this a guideline based or not? So with this thing in mind, this is the important one which we need to discuss. That bridging means using a short acting low molecular weight heparin to cover the gap when stopping a long acting agents like warfarin or dual antiplatelets therapy, and patient is on high risk and all that. So how long you need to stop and change them into the low molecular weight heparin? The half-life of low molecular heparin is about 12 hours. And we learned that from the anesthetist who would not give an anesthesia, who would not puncture the back, because there is devastating effect of hematoma and paraplegia sometimes in patients who would get a hematoma of the back. So the anesthetist will tell you 12 hours only. If you stop the low molecular weight heparin for 12 hours, they're going to put a spinal anesthesia. So there was a bridge trial which was done in 2015 and 16, and that showed that the bridging of the atrial fibrillation patients led to more bleeding without reducing the thromboembolic risk. And that was a landmark trial which was done and was published in the Lancet and New England Journal. And then that changed everything, and even the guidelines of EAU was changed based on that. So the paradigm has shifted, that the most of the dual antiplatelet therapy or warfarin patients don't need the bridging unless they are extremely high risk and the CHAD score of above 5. So the EAU guidelines, obviously based on the bridge trial, have consensus regarding this, and 2 recommendations basically. 1, discontinue antithrombotic therapy for the period around the surgery. In those with the temporary very high risk of thrombosis, that is CHAD score of above 5, delay surgery until the risk decreases. If it is not possible to delay without antithrombotic therapy, or bridging through surgery may be advisable. So you can, because the half-life of lower molecular weight heparin is less than dual antiplatelets, you can actually control that. You can stop it and then reverse that as well. So here's the summary of the recommendations for the dual anticoagulants. So stop 48 to 72 hours before any high-risk surgery. For warfarin, stop for 5 days before consider bridging only if high thrombotic risk. And with antiplatelets, we typically continue aspirin. Aspirin is not an issue. The issue is Plavix. And that should be stopped at least 5 to 7 days, and some people say a week before preoperatively. And if the patient is on the dual antiplatelet therapy, delay the surgery, and if within the 6 months of stenting, or seek the cardiology advice that most of us see, that patients would have had a drug-eluting stent put in, and they are put in on dual antiplatelets, and the question is whether we do some surgery on them or not. You cannot stop that, because the risk of getting occlusion is quite high in the first year. So the EAU offer guidelines with strong evidence for retrograde surgery being the preferred intervention in these circumstances, and if antithrombotic therapy cannot be stopped. So this table highlights the difference. The warfarin requires INR monitoring and is reversible with vitamin K or fresh frozen plasma. Dual anticoagulants have shorter half-life, the simpler interruption window, and the less need for bridging. And we generally are more comfortable continuing with the aspirin. And for example, in the PCNL, bleeding is increased, but usually controllable. Plavix is more problematic, and if a patient has a drug-eluting and stents placed within 6 months, it's safest to delay the surgery until a year is reached. And if the case is urgent, stop Plavix and continue aspirin, and involve the cardiology for the monitoring purposes. This is my scheduled approach usually with these patients, and assess the bleeding risk of planned procedure, determine thrombotic risks, stop the drug based on the half-life and agents, bridge if there is a high thrombotic risk, that is the CHAD score of more than 5, and plan for timing of the postoperative restart. EU guidelines used to say that start 4 days later, but sometimes I think you can start the next day if the bleeding risk is too high. Always consult the cardiology if there is any uncertainty around the stents or the recent cardiac events. So these are typical some of the situations and scenarios we encounter on everyday clinical practice. So this is a 65-year-old male, atrial fibrillation on apixaban, 2 centimeter stone in the renal pelvis. So what we do is basically hold for 48 hours before, no bridging required, restart 24-hour post-op, and usually it is quite okay. And if I'm doing a flexible ureteroscopy, I don't even stop the dual anticoagulant therapy on these patients. So another one, a 58-year-old female, mechanical heart valve. That's a bit dangerous. That can throw emboli. And on warfarin, 2.5 centimeter stone requiring PCNL. You have to really take it seriously, and you have to stop the warfarin for 5 days prior, bridge with the low molecular weight heparin until 24 hours, and some people say 12 hours, PCNL restart, and low molecular heparin 48 hours post procedure. Another case of a 58-year-old female, mechanical heart valve on warfarin, 2.5 centimeter. As you have discussed, this is the plan. This is a typical, one of my patients, favorite patients, 68-year-old lady with a symptomatic right side, but she had bilateral staghorns, atrial fibrillation, CVA, ischemic heart disease, recurrent UTIs. We have to do something about her. And she's not only on anticoagulants, she's on antiplatelets also. And the options were very limited on these kind of patients. So what I did was I had to do a staged FURS and under general anesthesia, obviously, for this procedure with bridging warfarin for 12 hours beforehand, but continuing with the dual antiplatelets. I didn't stop the dual antiplatelets, and there was no problem in these patients on clearing both the sides. So in emergencies, we do have two reversal options if they bleed. The warfarin with vitamin K and fresh frozen plasma, digagartran with the idrazunab, and factor 10A inhibitors can also be given on this availability. For antiplatelets, platelet transfusion is sometimes used along with desmopressin. Desmopressin has shown some promising results that it can be off-label used, and it actually prevents the bleeding significantly. So minor procedures, restart anticoagulation at 24 hours if hemostasis is secure. For major bleeding, for high-risk procedure, delay for 48 to 72 hours. And similarly, I think I'm going to quickly go through my last slide. So I basically, in essence, I strongly recommend developing a local protocol, as we have in my institution. Use MDT planning for complex patients involving the anesthesia, cardiology early. And if you have a good hematologist who has interest in on the subject, to involve him or her, and standardized form of checklist and preoperative assessment, reduce the omissions, and clear documentation of the planning and the rationale, and restart strategy is very crucial to prevent all that. So I stop here, and I'll be ready for any questions or comments if you have.